is the most greatest thing and the most greatest feeling. I know you guys are dragging right now because you're like, oh my God, there's still 6 months to go. Others still have internal medicine that is untouched, but you guys will pull through. It's almost over. That's all I can tell you. It's almost over. And in the end, you'll pat your back and you'll be happy that you did it.
So just yeah, so the first question I just wanted to ask you, so it's basically about the environment. You just tell us about where's the hospital, Bara, the type of environment in terms of safety. Just explain to us, just paint a picture, yeah, in that regard.
Okay, so Bara is at the beginning of Soweto. That's how I can put it. It's just at the beginning of Soweto. Because soon after or soon from N1, you just come straight into Bara. It's at the beginning of Soweto, and everyone knows that Soweto is very, very huge. So this makes it to be relatively safe in a way, because it's not like in deep Soweto, like how everyone is so scared of Soweto. It's not very deep into Soweto, but the issue is the clinics are located deep into Soweto, but otherwise it's relatively safe. It's like I'd like to put it as like it's a gated community in a way, because you're within the hospital. So in terms of safety, it depends also what you're driving. That's how I'm going to put it, because the year before I came in here, they said in terms of safety, they've had car theft happening, but last year and this year, nothing has been happening. So they toughen up the security system, they check the gate. Yeah, it's relatively safe. So yeah, and they are, if you live inside the DQ, there are two malls. It's Maponya Mall. There is a Southgate Mall. It's not very far, honestly. So I can say it's relatively safe, depending where you live, whether you live inside or outside.
All right, thank you about that. And also, was Bara your first choice? And I just wanted to know, what was the criteria that you used to pick the hospital? Because we are finding it difficult to pick our top 5. So maybe you can give us some pointers on maybe how do we actually pick our top 5? Or yeah.
Okay. So what I always tell people, or you guys, like on how to pick your hospital, it's based on what do you want to get out of internship. Do you prefer to live in a nice environment? Do you prefer, like, you place your criteria? What do you want out of your internship? Like, do you want to learn out of your internship? Do you want to learn a lot out of internship? Do you want social life out of internship? Do you want to just have a free time out of internship? So for me, it was mainly, I didn't want to be in KZN. I grew up there. So I was like, no, thank you. I'm tired of KZN. So I wanted to choose something that is outside KZN, of course. Number 2, we were COVID babies. So that meant that 2 clinical years, we couldn't like exactly be fully exposed to clinical practice, which meant that I needed more practice so that I'm comfortable. So Bara was the option for me because I wanted to be good at what I do, right? So I looked at the intake of Bara, which is like, she has a huge catchment, basically. It has a huge catchment. So I'm also the type of a person who learns by seeing things, right? So I wanted everything to become my second nature so that I learn easily. So for me, it was that. I didn't care much about the salary because I know there are people who are like, how much do you earn, doc? Like, how much is it? Because it's a lot of work. If you look at it, it's a lot of work. So you have to compare the two. Is it, do you want the academics mostly, or do you want money? Guys, if you want money, don't come to Bara. Just don't come to Bara, because out of everything that you do, you feel like the salary is not much, basically. So it's based on what do you want out of out of your internship. If you want a social life again, I wouldn't advise you to come to Bara. If you want to have a good living environment, you can come to Bara, but don't choose DQ. So there's a lot of that. So it's based on what do you want, and don't care about what other people say. Honestly, yeah.
Right. And then what languages would you say are predominant in that area that are spoken there?
It's Sotho and Tswana, but what I found out is that people understand Zulu here. People understand Zulu, so you're able to communicate with them in your language and they will respond in their language. So, which is how I ended up learning their languages as well. Yeah.
All right. Okay. And then I also want to know about the DQs. So can you just tell us about the DQs? How are they? Are they fully furnished? What would I need to buy if I'm moving into your DQs? How much is the rent? I just want to know, just paint a picture as well.
Okay. So DQ is divided into two basically, right? So there's old doctors' quarters and new doctors' quarters. The old doctors' quarters, it was renovated. So you have a little bit of your kitchen, your wardrobe, then the bed. The bed is very uncomfortable. So I would highly advise that you prepare yourself, or you just save some money to buy your double bed so that you're at least comfortable. It's one of those beds with the mattress and the metal thing. We used to call them braai stands back in medical school. And it's very uncomfortable. So what you need to prepare yourself, or rather to buy, the bed, definitely. You need to buy yourself a stove, guys. It's a tiny area, and you're gonna need to buy yourself a stove. You're gonna need a fridge. You're gonna need to buy yourself a fridge. And in some of the rooms, like in new doctors' quarters, you need to fit in a table, but you can barely fit in a couch. I'm sorry, you can barely fit in a couch. That's the first year room that I had. So you have, it's very tiny, guys. That's what I'm trying to say. You can fit in a bed, a fridge. I've seen others putting in a TV, but you barely have space to move in between. And then couch, no. I've seen someone buying a couch and it didn't fit in. So and you pay 900 Rand until you move into the second year rooms, which is very spacious. You have your lounge, you have your kitchen, you have your bathroom. Oh, and in old doctors' quarters, you have your own bathroom. But in new doctors' quarters, you have to share a bathroom, which has showers and toilets. And then you don't have a commune area for the kitchen. So you have to make your little kitchen there in your room, your tiny room. Yeah. And on the second year rooms, you pay 1.2. Yeah.
1.2. And then I was also speaking to you the other day. You mentioned something about sharing a bathroom with 10 other people. Can you elaborate on that?
So it's almost 10 people, right? So you guys have your room in your corridor, right? It's like rooms, about, I'd say 5 this side and 5 on the other side. And then you're gonna have to share a bathroom, which is 2 showers and 2 toilets. The hygiene there, because now you're sharing with a lot of people, it's not very cute and not very good. So yeah, and I'm not gonna lie, sometimes the cleaners clean, sometimes, yeah.
And then where do you guys do your laundry? Are there washing machines available? Is it like this, or do I get my own washing machines? What's happening? I need to know all of these things.
I've seen people buying washing machines, but it's better to buy a washing machine in second year apartments, right? The first year apartment, I did a washing this one time, and your thingy, your line is like at the top on the rooftop, Not a very cute rooftop, okay? Please get me there. And I had my scrubs missing. So you can wash, but if only you're gonna just sit there and wash your clothes. But the alternative is that there are laundry people around Soweto, or at least Deep Kloof Zone 6, which is just not very far from here, in which they wash, they dry your clothes, and depends if you want them ironed or not. So yeah. So I ended up opting for that because, yeah.
Okay. And then you didn't also mention, how far is the DQ from the hospital? Can one survive without a car?
Yeah, I still don't have a car. I'm driving my brother's car, which most of the time on weekends it's not there. So you can survive without a car because you can request to these malls, which are very close by. And the DQ is literally inside Bara. It's just that Bara is huge, guys. It's very huge. From here to Obs and Gyne complex, it's like 10 minutes walk. So it's very huge. Everything is just spread apart, but it depends on which rotation you're in. If you are in psych, I'm literally watching psych wards here. If you are in internal medicine, it's a little bit of a walk. So it depends where you are.
Right. And then I also just want to know the salary, the amount. How much, if I was to work in Bara, how much would I expect as a first year intern, and is it inclusive of rural allowance or not?
Hey guys, we don't have rural allowance here, hey? We're supposed to have danger allowance, but we don't have that. We don't have danger allowance, we don't have rural allowance. It's just standard salary, which is 47,000. And I think I think now it's 47,000. It increased this year, if I'm not mistaken. Yeah, I think it increased this year. Yeah, it's 47,000, unfortunately, after all the work.
Okay, but that's quite compared to what we are earning now from NSPAS money to our, that's great, eh? All right. And then I also just want now to ask you about your overall hospital experience. So you can just take us through the blocks and just comment on each of the blocks.
Okay. So again, Bara is huge, guys. Bara is a tertiary hospital, but at the same time, because of a very huge catchment, it can serve as a clinic. It can be like a district hospital, because you'll come across all these things at the end of the day. I always say unfortunately, because I know the KZN system, in which you don't get into a tertiary hospital without a referral. Sometimes sometimes you do come in, but I think they're phasing that into only people with referral letters are coming into Bara. So we have ED, in which it's divided into three. We have trauma emergency units, we have surgical emergency units, we have medical emergency units. So I know a lot of units, it's like trauma and surgery all together. Here, because I think you guys have heard, it's like the trauma has like the biggest trauma unit in the country, because it's Soweto, man. And then the surgical, which if you're doing surgery, that's where you're going to be doing your calls. Medical, it's mainly for ED for second year. So let me take you through the rotation. So in surgery, you have trauma. It's different units. It's trauma units, it's vascular units, burns units, unit 1, which is hepatobiliary, unit 3, which is colorectal, I think it's unit 5, endocrine, and unit 2, which is breast. And then there is ACS, which is it's acute what? But it's those acute surgical issues that they have. So basically in trauma, anything that is trauma related, a stab, is it polytrauma, PVA sometimes, but it depends if is it mainly ortho or is it mainly trauma. So we have those. So the recursives of surgery and trauma, they happened in the trauma units. And then trauma interns, there's plenty of them. I think there were 10, if I'm not mistaken. I think there were 10. So they run trauma, the trauma side of the surgery, basically. So, and then there's vascular. Anything vascular related, you chopped off your leg. If it's vascular related, there are interns there, and I think it's 2 interns if I'm not mistaken. And then there's burns as well. Any type of a burn, electrical burn. If you've burned, that's where you're going. So, and then there's hepatobiliary, colorectal, endocrine, and breast. So as you can hear it, it's those issues there. So there's ACS, in which it's like a triage of some sort of where patients are actually going. But the diabetic foot, because we're gonna have to chop that off, and then you can go home. They stay there. That's ACS. It's like those acute surgical issues that patients have. And ACS has a number of interns as well. I'm not sure. I don't remember if it was 7 up to 10. So it depends how well staffed you guys are. Sometimes there is an unfortunate event in which you guys are very short staffed. So 5 interns at least per unit, which is hepatobiliary, colorectal, endocrine, and breast. Hepatobiliary, guys, I wouldn't advise. If you get or you lend to Bara, try to dodge hepatobiliary and ACS by all means. That's if you are coming here. It's not a very chilled unit, because let me put you into perspective. So I was in hepatobiliary, so you come into work at 5:30 a.m. and in the first month, probably you're going to leave at around 8 or 9, because you're not very used to the environment, right? So you're still trying to get the hang of it. So your working hours are insane in surgery, I'm not gonna lie. ACS as well, I think they'll explain the same thing. I think they started at 6 and they may end very late, because now they have their own patients that they're allocated to them. And basically, yeah. And then in surgery, there are WAD calls, and then there's SEU calls or TEU calls, depending on where you are. If you are allocated in trauma, vascular, and burns, you're going to be allocated in trauma surgical units. If you are in other units, you're going to be allocated in surgical emergency units. So WAD call, guys, you are the intern, and there is a reg in ward 7, which is a high care ward. So what happens is that if there's any emergency that is happening in these wards, which is from ward 2 up to ward 10, you are responsible for that, except for ward 7, of course, because it's a high care ward. So you have to manage these number of wards in which you will get a call every time there's an emergency. So there's just one intern allocated for WAD calls. What happened to me is that there were 3 resources at the same time in different wards. Mind you, it's not like you're just crossing over to that ward. Wards are huge as well. Other wards, they have about 50 patients. Other wards have about 40 patients. So it depends on a ward how much they put in that ward, or the maximum of that ward. So I had 3 resources in 3 different wards. Started with 1, I did a recess, and then as I could see that the patient is going towards being better, the BPs were picking up. Then I got a call again mid recess. Then I had to leave this recess and ask the sisters that, can they call me if the patient is dropping the vitals basically. Went to the other recess, the patient was bleeding. I had to try to stop the bleeding. They've tried adrenaline dressing and all of that. Everything is dropping. The BPs are dropping. Couldn't find IV line. Called the senior. The senior has a resus in ward 7. So now with this patient, now you have to assess what's the success rate of this patient. But it was a CA breast patient, and the prognosis was poor for her. So because it was my first call, it didn't go through the file, to be honest. I just was like, oh my God, this patient is bleeding. She's sleeping on blood. I have to find IV line. I have to try to resuscitate her. That was the main thing. But I had to look at the file, and the prognosis was poor, and she was not for resuscitation. So I spent a whole, minutes, 30 minutes in one patient that I could have like, moved on because the prognosis is poor. Then the third resus, while mid-resus on this patient, after discovering that her prognosis is poor, then I had to go to another one, right? So, and then while on the other one, I got a call from the first one. So I'm trying to put you guys into perspective, what is expected of you. So sometimes the senior is not there because they are also dealing with resuses. So you are responsible for that. Going through that, there are red flags in which there are patients that you have to see during the night because they are not in a ideal state, if I may put it like that. So you have to check up on them and make sure that they are fine, their vitals are fine. Are they still bleeding after theater? You have to check all of those things. So sometimes you may end the night without sleeping at all. Mind you, the call starts at 4 and ends the following day. High care bloods that need to be taken, you are responsible for that. Some seniors are nice, some seniors are not very nice. So other bloods, you have to take them at 8, at 10, at 2. So it happens sometimes that you are unable to do all of those things. So yeah, that's surgical. And in SCU, there are 3 seniors, one senior reg, and maybe a junior reg, and then maybe an MO or a ComServe. So there, most likely you are never alone. So that's the nice part about SCU. And then there are 3 interns in total. You will see a high number of patients depending on, was it a month end? Was it a month end? Was it, what was happening around Soweto? Was it a game? Was it a derby? So you have to look at those things and prepare yourself for the worst call ever. Okay, then moving into internal medicine, I'm going to try to be as fast as I can. Moving into medicine, there are 5 units in medicine, right? Internal medicine is very reg dependent, very, very reg dependent. I know other people are like, no, Mohammed's unit is nicer or Peter's unit is nicer. Yeah, it's very reg dependent. If you have a nice reg, you're going to have the best time of your life. Even though patients are allocated to an intern, not to a reg, not to a consultant, not to a unit. You as an intern are responsible for that patient. So this is how it goes. You become on call. There's a call, a main call or a long call. There's a wide call. There is a short call, in which a short call, which means between 7 and 3 p.m., you're admitting patients, you're seeing patients, you're admitting. Most likely patients that come from MEU to Ward 20, which is our admitting or admission ward, they are most likely admissions, okay? So between 7 and 3, it depends how many patients you get. Minimum, I can say you can get 5. Maximum can go as far as like 10, depending on a day as well. So those patients are specifically yours. And when you get into internal medicine, there are patients that are being handed over to you. Like when we got handed patients over, I think I had like 15 patients, right? So it was a nice way to start the rotation because I was still adjusting, right? I was still adjusting to internal medicine, but at least I had done surgery. So you have those 10 patients. Let's say you are short call today and you just came into the rotation, which means you have like 15 patients that are yours that you have to see. Between 7 and 3, you must be seeing these patients as well, your 15 patients, right? And then you admit another, let's say 5, which means now you have 20 patients in total that you're going to have to see the following day. It may happen that the following day you are on a long call, right? So you may have admitted 5, that is brand new. The following day you are a long call. So long call depends. Are you between 4 to 10 or from 10 till the following morning, which is 7? So when that happens, it becomes a mess, basically. It's draining because now the admission of a night call can go up to as 20. So which means you have 15, you have that 5, which is 20, and then you're admitting 20, which is 40. You can have 50 patients as an intern all by yourself. So the discharges, you are the one who's responsible for discharges, managing the patient, make sure that the patient is fine. As much as there's always supervision, there's always a reg, especially during the day, in which those are the time you have to do your procedures. Your BMATs during the day, your LPs during the day, in which it ends up being a lot of work because now you have to see patients, you have to do procedures. And luckily there are flabs, but flabs are up until a certain time. So you end up trying to bypass the system in which you know that this patient is going to need bloods the following day. So you put in you write the form, you put in their box. So you end up like working around it. First days are the worst, but as you get used to it, you become fine. So patient has low HB, it's you. You have to see that this patient has a low HB, then manage the patient further. You are fully responsible for that patient. If the patient die, you have to find out, basically, well, not like find out, like they say that what happened, but you have to think what might have happened to a patient. There are interns who have been held accountable for things that they were the reason why the patient might have died. For example, you have a patient who's coming in with TB, you do the LFTs, you forget to check the LFTs of the patient, and then you start the patient on TB medication. And then the patient dies because of the liver, right? So you are held accountable for that, because the main thing, the reason you get out of medical school is because you are a safe doctor at that particular point. So there are such things. But if you don't know, you are not sure, you can call the reg. You have your reg, which most likely has 2 interns allocated or up to 3 interns. They round with you. So in the morning, you round all by yourself. I've never volunteered to wake up so early in my life because I wanted to leave early. But, well, it didn't happen. So woke up at 6, rounded with my patients, and then rounded with the reg. Other regs, they will help you with the rounding, right? Especially at the beginning. I had a nice reg. The beginning, I rounded with the reg, and my reg was telling me the important things that I needed to do on the day. She was like, you need to do bloods on this lady or in this gentleman, maybe like up to 5 things that you have to do that are urgent, right? And then after that, you can see it the following day. But the issue is that these things pile up. You are responsible for booking the scans for the patient, guys. You're just responsible, fully responsible for the management of your patient. But what I liked about internal medicine is that it's flexible. They allow you this, the moment the senior is comfortable with you looking after the patient, they are comfortable with you taking care of the patient. And all you have to do is just, they ask, are you worried about this patient? And you're like, no, I'm not worried about the patient. Then you move on. The round becomes quicker. On other days, depending on the unit, you may have to round with the consultant at least once a week. You have to round with the consultant. The favorite thing about rounding with the consultant was that you discharge a lot of patients because it's a tertiary hospital. If it's a tertiary hospital, they don't have to stay for longer up until you see them that they are physically well. They have a good judgment in terms of, oh, this patient will be fine. As long as they take medication at home, they can go home. So you get to discharge patients as fast as possible. So that's mainly it about internal medicine. I'm forgetting one thing. You may be on short call, having to see your patients, and be required to be in MOPD. So on those days, you have to juggle around a lot of things. It's tiring. And I'm not gonna lie, in my unit, all your patients were yours. So which meant you have to work 7 days a week, which means Saturdays and Sundays, you see your patients, but it depends how you want to work around it. In other units, there's a cover system. In my unit at that time, we didn't have a cover system. And we decided that me and my partner, who we were paired with in one reg, we decided that, because like there's a time where you can see that your partner is drained, like he's tired. Now they're making mistakes, and he can also see that I'm making mistakes because I'm tired. So that's the nice thing about the buddy system of being partnered. but it must be a nice person, of course, or a person that you guys, like, you talk with at the beginning, like, bruh, if you can see that I'm slacking, tell me, right? Because when you round with your patients and their patients as well. So that's internal medicine. And then there's obstetrics.
Hey, Doc.
Yes.
All right. Okay. Because of time as well, we also want to open the floor up to questions. I know.
Okay.
I'm sorry. But I'll just let you speak about the last few, and then we'll open the floor to questions from the students. Is that okay?
Yeah, that's
right,
fine.
thank
Let me try
you.
to go quicker. All right.
All right.
So then there is obstetrics. Obstetrics, 5 units, and in 5 stations. There is clinic, there is admissions, there is there's clinic, there's admission, there is first stage and the floor, there is theater, and there's Psychiatry, right? So each unit is allocated something on the day, right? So you get there in the morning around 7, and you see your patients, in which it's not the entire ward. So they allow it's different. It differs per reg. Sometimes you're expected to see like 5 patients and then go be where you're allocated. Sometimes the reg will want you to see all patients, but matter of fact, apparently you're supposed to see like 3, 4 patients. At some point, I'm not sure if my regs were taking advantage of me. Then you're supposed to be at the clinic. Everything that is seen by the reg, you're supposed to come back and do if it's blood required or anything that's procedures, you're supposed to do them. In terms of wards, I think there are 5 wards for antenatal and postnatal. Antenatal has 2 wards, then the rest are postnatal. There may be procedures that you're actually required to do, like the bulbs and all of that. Then there are 3 gynae wards. There is an admission gynae ward, and then there are 2 gynae wards. They are separated per unit. Gynae calls, you're supposed to be there for 24 hours. Obstetric calls, you are there between 4 till the following day. In obstetrics, 2 interns are required to be in theaters, in which it's 2 theaters. So guys, those theaters, they don't close. If we've run out of emergency, they go into elective slates. So roughly they want to do 10 scissors per night. But sometimes, like most of the time, it's like up to 7. So you stand there the entire day. In admissions, you're responsible for admitting all the patients, but there must be a senior there. And there's someone who's allocated 1 person on the floor, but it depending on how well staffed you are as interns. 1 person on the floor responsible for anything in labor ward, anything in high care, and anything in first stage in terms of bloods and procedures, basically. When you're done, go help in admissions because most likely they need help. In high care, there is a reg that is put in high care and first stage and labor ward. So all you do is just procedures. You don't see patients there. And then in gynae, for admissions, you see all the patients. You manage all the patients accordingly. The issue is that generally in all hospitals, the patients that are emergency, you really see patients that are actually in emergency. You see a lot of patients who are just coming with things that could be seen the following day, but there are emergencies sometimes. Then pediatrics, 4 units, which means we are on call every 4th day, with obs and gynae on call every 5th day, and then on weekends they juggle around. Yeah, there's a list for that, and I'm not sure how it works, honestly. I just showed up when I'm on call. 4 units on call every 4th day, divided into 2: day call, night call. Day call, you do the day till 10 p.m. Night call from 4 till the following day, so it overlaps. Then for us, there were 5 interns. With 5 interns, that's how we had to split ourselves into 2. So it depends. Sometimes you have an MO, which makes it 6, but yeah, it's 5 interns mostly. Well staffed, could be more. Then there's neonate. Do neonate for the first month, for 1 month. Sorry, for 1 month. neonates, guys, you're responsible for the nursery. So every child, every FD that's in theater, you are the first person who's in contact with that child. So you have to know how to resuscitate a neonate. Luckily, they do a course for you to be able to manage a patient basically in resus because you are responsible for that. There are 3 regs that are allocated there, but not in nursery. They are in TICU and NICU. So there is a reg who will come down should there be an issue that you can see that you are unable to manage. So in neonate, you see patients in Ward 66, which is packed. It has about normally 100, when they squeeze in, 104 babies, depending on how well staffed you are in during the rotation. So sometimes they allocate interns in per cubicle, which is roughly like 10 babies per cubicle. And then TICU, you see those babies, it's a transitional ICU, so there's low birth weight, jaundice, and a step down from ICU. So you also see those babies as well. There's Ward 41 are babies who are semi-fine, but they could also get sick sometimes. It happens. But the Ward 41 babies are being seen by the peds team that is on call because the ward is very far from neonates. Psych has 2 female wards, 2 male wards, 1 adolescent and 1 child ward. So it's you have special clinics, you rotate in child psych, there are consults or MEU, and you are located in child in psych wards as well. There is also a clinic, so you end up rotating in all of these. Sometimes I ended up not getting one of the weeks in which it was MEU and consults. So sometimes it depends how the roster is made up. Orthos divided into units. Orthopeds, in which orthopeds is 2 interns in the peds, which means you are allocated in trauma, but you don't see trauma patient. If there's a broken bone, you are the one who's to see to it. There is 2 interns and 1 senior, could be an MO, could be a reg. Then there's spine unit, which has 1 to 2 interns, tumors and sepsis, 1 to 2 interns, peds, 1 to 2 interns. Lower limb and upper limb, they are the most packed ones, which means they have most interns. I'm not sure how many they were, but I think they were roughly 5. And there's hands, in which I think had 2 units. There's sports, which means I think had 1 to 2 interns. Depend how well staffed you are. Okay, so when you're in the orthoped, it means that you admit all the patients that are coming in that are also related. In the clinic, you see arthritis and all of that. Then almost done. I'm almost done. So there's anesthesia. And anesthesia, 1 month you're allocated to a reg, 1 month you are just floating. In that 2nd month, you are expected to see pre-medications. You're expected to be able to manage theater, sometimes all by yourself. And they emphasize more about punctuality. They want you to be there on time. And then the ET tubes, guys, you're going to do a lot of ET tubes. They want 50 and you may get the 50. Sometimes you don't get because there's high competition. There's EMS that want to put in ET tubes. There is a reg. There's just, yeah. But sometimes you get it. Sometimes depends on how you're allocated. Then spinals, you're going to get all the spinals you need till you're very annoyed with the spinals. Then family medicine. Family medicine, 6 clinics, 2 EDs, 2 district hospitals. 3 months and a week, 3 months and 2 weeks, you're allocated in clinics. There is 2 weeks of COPC in which you see a lot of chronic patients there. You counsel them appropriately, like it's those things. 1 month in ED, you are supposed to be in MEU, or there is there's Begimlangen District Hospital, which also has an ED. So it depends on these 3 clinics, which one are you allocated to? So you can either be in ED here in Bara or in ED in Begimlangen. District Hospital, 2 hospitals. Lens District Hospital and Begimlangen District Hospital. So here, guys, you are very independent. I was shocked to see this. You just get to the clinic and you are the doctor. You are just the doctor that is there. But what I liked is that honestly, Bara prepared me for all of these things. But when you don't know, obviously there's an MO to ask for help. And the sisters, they are very, very brilliant. So yeah, that's how the rotations goes. I'm sorry. It's a long thing because it's a tertiary hospital. So sorry.
No, thank you so much, though. You really painted a picture. Bara was my first choice, and now I know exactly what to expect, you know. So I know when I make that decision of putting Bara in my top 5, what I'm getting myself into. Okay. Yeah, it sounds like you guys get exposed to a lot of procedures as well. Because the other day you were telling me even you guys are doing BMED as well. Because I'm currently rotating in Stenger Hospital, and BMEDs are only done by the MO. So like that's also like I think one of the perks, you know, of being at Bara, you know. Okay.
You do everything.
Thank you so much. All right, so I'll open the floor to questions. So you guys can just raise your hands, and then when I do call out your name, you guys can just switch on your mic and ask your questions, and then Dr. Njapha will answer your questions. Let's see if we have any hands. Okay, I do see a question at on the chat. So they're asking, Uguti, does Bara have any assessment? So do the interns get assessed? Because there are rotations where interns get assessed as well.
Yes. So basically, in every rotation you get assessed, right? But also sometimes it can be very unit dependent. There are units where you're expected to write tests. You're expected to write entry tests and tests after the rotation. And sometimes they assess you based on just the reg, what the reg says about you. So it's very subjective sometimes. So yeah, I haven't had any formal assessment, or except for anesthesia. And apparently in FemMed, we're supposed to complete some HIV course before that. And that's literally it.
Right. Okay. Do you guys have any other questions? You guys can just switch on your mics and ask. Okay, let's see. Simlindile, all right, has raised their hands. Hi, Slindile. You can ask your question.
Hi, Dr. Njapha.
Hi.
Okay, I wanted to ask, like, during orientation, like, what happens on the first day? Are they expecting you to work, like, the minute you get there, or they, like, take you through the whole thing? Like, please let us know what basically happens during orientation.
Okay, so I'm not sure if I got you completely. I think I had an unstable connection, but there is an orientation, right? At the beginning of the rotation, especially for surgery. I think the first rotation, the first time you get into Bara as an intern, that is the most important rotation or the important orientation that they help you get through, because the formal rotation of the hospital, we got it, I think we were in February, if I'm not mistaken. By that time, you know the entire hospital, because you have to run around like a headless chicken. But they do orientate you based on your unit that you are allocated into, which is very important. And then after, you get like a general orientation. And then that's it. Sometimes you have to orientate yourself. Some of the things you just get them along the way. Yeah.
Okay. And Mslindile was also asking, like, the first day you get there, is it the first day you start working? It's just first day for admin and orientation.
I was on call on the first day, on the 1st of January, 2023. So you get there, we are expected to like be able to cloud patients. They're very patient, Shem. Some regs or some seniors, they're very patient because they understand that you have straight from 6th year. And the last time you may have done the rotation would have been the previous year in January. So yes, they Shem, they are very patient, but you're expected also to be able to point out like the critical things or like the danger signs or like some of those things, like be able to point out this is acute pancreatitis. Sometimes because you present the patient, sometimes you may have missed these things, but they give you like a week or two at least to, get into the game. Yeah.
All right. And then I have a question from Jordan. They're asking, Nguti, are there any students rotating at Bara? And then the second question is about the payment. Is the 47K before tax, and does calls or overtime add to the total?
Yes, calls and overtime add to the total. It's 47K after deductions. Sorry, it's after deductions. To be honest, I'm not sure before deduction how much it is, because that broke my heart when I saw it's how much it is and how much they're taking. So yeah. And then you said
right. And does Bara have students?
Bara does have vet students, but I prefer to at least not put or think about that too much, because they are also students. You were also in their shoes at some point. So personally, I preferred, if they are interested into learning, I'm gonna guide them through that particular thing. But if they're rushing to go to learn some clinical stuff, they go learn some clinical stuff. But there is a rotation where you're expected to rate the student as well. So there is that. So just don't put it in your head that they are students and you're gonna use students to do your work. Sometimes it doesn't help. Or else, like, how you were as a student. Let me just put it like that.
All right. You guys can also raise your hands and then ask your questions. Okay, let's see. So we have a question as well. So what happens if, for example, you fail an assessment? What happens? Do they make you repeat the block, or they later slide, or what?
So, like I said, if you do something, it depends on a consultant, basically, because sometimes you'll find these things that they've been reported to a consultant and you're not even sure who reported it to a consultant. But such cases do get to consultants. I've had people repeating the rotation, but sometimes it's very biased sometimes in other rotations. So yes, I've seen people repeating rotations, and sometimes you just have to show up, guys. Just show up.
Ooh, okay. And then do the students help with the what work? Are they any help?
It depends. It depends on a rotation. Like I said, I just prefer to forget about the students because sometimes they have a lot of work to deal with. Sometimes, apparently, there's a student allocated to you and your reg, but you've never seen this, guys. Sometimes you just never see the student, and that's why I ended up saying it's okay. Just don't rely on a student, guys, because we've been students and we know that we always rush to get home. Okay.
Yeah. And then in terms of communication, do you think someone who only speaks English will survive? I think.
Yeah, definitely you'll survive. Sometimes it's nicer, to have a colleague who knows a different language, but hey, fam, I made it work. That's all I can say. The only language I came here with was Zulu, but you make it work. I've seen also only English speaking people surviving. Like we're in second year with some of them, and yeah, you can survive.
I also just wanted to know, I think this question that is asked on the chat is basically about work-life balance when you're working in Bara. How much of time off do you get? Or do you work all the time, most weekends? Like, do you actually have a work-life balance? Oh, because sounds like you guys work.
I'm not gonna lie. Surgery, none. Internal medicine, 0, because you're in hospital majority of the time. So that's why I ended up choosing DQ, because I noticed that I'm spending majority of the time. The only reason I go back to DQ is so that I sleep. Sometimes you pass out and you've ordered something and you can't even hear the phone ringing, and you wake up the following day because you are so tired. But I've seen people leaving within these rotations. I've seen people going out to party. I've seen people getting their partners during these rotations, but I wouldn't say it's ideal. Same way I wouldn't advise someone who's planning, for example, to have a child and next year and applies in Bara. I highly wouldn't advise that, honestly. It's a lot of work. It's a lot of work.
All right. Okay, and then in your first year, what time did you finish on average? What time did you guys go home?
Depends if it's the first month or the second month or the third month. First month, hey guys, you can go home at 9 p.m. because it's just a lot. And it depends if the registers that you're with, is it the new registrars or the registrars who have rotated in that particular rotation or in that particular, basically depends on, is it senior, is it a junior doctor or a junior reg. With internal medicine, at some point you do work, and then you notice that you are phasing out, like you're no longer within, or you're no longer able to see patients. I would take time, go to DQ, eat, watch something, come back. I remember bumping into my colleague at 9 p.m. We were still seeing patients at that. Those are the worst times sometimes. But at the beginning of the month, do expect that you will leave very, very late. You will not have a social life. You won't have time to even respond to a simple WhatsApp text. Another thing, you may slip in and out of depression before you know it. And you realize very late that, oh, damn, I was actually depressed at this time. So people who live with their families, I highly recommend that. Live with your family. At that time, at least, if you're rotating in surgery, internal medicine, just try to leave. Have a friend. Live with the family. If you have a partner, live with a partner. Because you go through it. I'm not gonna lie, but you have different perspective of. We have different perspectives of Bara, of course. Yeah.
All right. Okay, I'd also ask you to share some of the videos or pictures of the DQ. So someone is asking about how decent the DQs are. I will share the videos with you guys. I'll ask who to send it on the SAMSU group. You guys are gonna get the video so that you guys are gonna make informed decisions. Okay, and then there's a question from Andre. He is asking almost nearing the end of internship, if you could choose Bara or another hospital, would you have chosen Bara again?
Definitely Bara again. Definitely
nice.
Bara again.
Mm-hmm. Nice. Would you like to elaborate on that?
Oh, so basically you see this at the clinics, right? When you go to the clinics for FedMed, I'm not gonna lie, you realize that you've actually grown so much compared to what you were at the beginning of the year, in which that was my aim really at the beginning of the year. I wanted to grow so much as a doctor. So you get there, you are very comfortable with a lot of things because you've seen them repeatedly. Mind you, it's different treating someone in a primary healthcare and in a tertiary institution. But you are able to see that this person probably has this. Your diagnosis, they become a lot better. You are able to pick up a lot of things a lot better than how you were back in sixth year, because you've seen a lot of these things and now they become your second nature. That's why I say, and I'm comfortable with a lot of procedures, even CVPs, even. You are able to put in a CVP because in internal medicine, you're required to know how to put in a CVP.
That's lovely. All right. And then, I see your hand is raised. You may have the floor to ask the question.
Yes, thank you, Sanbon. Like from what you've said, it seems like it's a big plate actually. It's not even a plate, Kara, it's a pool actually. So how do you move from being a student now to transitioning to being a full doctor? Because now from what you've said, it's like we are moving from a grade 6 student writing an exam to a grade 12 exam now, and it's a seems like it's a lot. How do you transition from those two areas? Thank you.
So basically, what I had told myself is that Bara is going to be the worst thing I've ever chosen for myself. So I actually expected the worst. And when I came in here, it wasn't as worse as how I expected it to be. But another thing that's helpful is that you recognizes your weaknesses. You are able to tell the senior that no, I don't know, I'm not very comfortable with this, or I don't know this. Because as an intern, you're basically a supervised doctor, right? So get into internship with that you are a supervised doctor. You don't know everything and anything, right? You are here to learn basically. So the moment you have that in your mind, it becomes a lot better because now the pressure is not too much on you and you rely a lot on seniors because, like I said, there's a lot of supervision in there, especially at the beginning of the rotation gym. They really, really help you. And up until they slowly let go of you, when you are comfortable, then they let go of you, basically. It's not like, well, it kind of feels like you're being thrown into fire and or being thrown into the sea and you don't even know how to swim and they say swim. It's almost like that, but at least there is a lifeguard watching you to see if you are drowning or not. That's how I put it. So you are able to adjust in a way.
Right. Thank you. Oh, that's good. And then was Bara your first choice? And then do you know if there are people who got allocated to Bara when it wasn't their first choice?
Yes and yes.
Top 5.
Bara was my first choice. And yes, you do get Bara without applying for Bara. It's like I believe that's everywhere. That's literally just everywhere. But the nice thing is that when you choose Bara, you're well prepared. You know that you're throwing yourself into the fire, and that's fine. The issue is when you're not very much prepared for it. People drown. People start antidepressants at Bara. I think also even when you think you are prepared for Bara, you do get to that point that you are drowning basically. But the main thing is that you are able to tell the other person or try to get help as much as possible. But yeah, basically, guys, I don't know. I don't know if I've answered the questions like the way you wanted me to answer, but yeah.
Right. And then in terms of people who are not staying at the DQ.
Sorry, can I say last year, this just crossed my mind. Last year, a lot of people who didn't choose Bara ended up in Bara somehow. And the people who wanted Bara, apparently, this is just from what I've heard at least, people who wanted Bara, they actually didn't get it for some reasons. I don't know what was happening. But it seemed like it happened a lot last year. But with us, there were plenty of people who chose Bara and ended up here. Yeah.
Right. And then, okay, in terms of people who are not stayed, who decide to not stay in at the DQs, are there safe apartments around the area? Especially like for someone who already has a child and a nanny, or is it totally impossible to be a parent and work at Bara? That's a question from Musamge, so they want to know.
You can work at Bara and be a parent at the same time. It's just that you're going to have to try to juggle around that a lot. You're going to have to use a lot of energy towards trying to make your life balance. But I've seen people with kids working at Bara. Also, you must have, I think it goes back to have an understanding partner, I think that goes a long way as well, because you know that you are actually not alone. There's someone who's going to hold down the fort while you are fighting for your life, basically, in Bara. So there are people with kids, there are people who have fallen pregnant. Yeah, it's just that normally I'd say, I wouldn't advise that. But yeah, it does happen.
All right. And then, okay, I saw a question on the chat where they were asking about working at Bara advantageous in terms of employment prospects for the future. Yeah.
Yes, definitely. I've seen, however, it has happened that we had, I know someone who was an asynchronous. They didn't have a job for a couple of months, and yeah, and then they ended up getting a job later. But from what I'm getting from the seniors, having Bara there as part of your CV, it says a lot about you. It meant that, oh well, this person is here, which means they survived Bara. They're gonna literally survive anyway.
Nice. Right. It doesn't seem like we have. Okay. Will you recommend Bara for someone not confident in their competency and struggles working under pressure?
Competency-wise, I would recommend it. Hey, but you said that the last part was
Okay.
it's
So they're
competency
asking, and they struggle to work under pressure.
the under pressure part. It's difficult. I'm not gonna lie. I wouldn't advise that, because sometimes you're gonna have to work under pressure. Sometimes the seniors, they're like, no, you have to do this. The previous team was able to do 1, 2, and 3, and that puts a lot of pressure on you. Sometimes you go back home and you cry, because sometimes the seniors are not all nice. Sometimes the seniors are all not nice. And sometimes they may tell you that you must be knowing 1, 2, and 3, and you don't know this. How dare you, and all of that. So sometimes it's a lot of pressure. But in terms of competency, I came in here, I wasn't competent, and I wasn't very confident with my clinical skills. I even doubted that I chose the right career. But out of everything, now I'm very comfortable, and yeah.
Right. So if we rate Bara out of 10, what are we rating Bara?
So the rate is mainly dependent on what I wanted to get out of Bara. Did I get what I wanted out of Bara, or did I not? So my main thing was being a competent doctor. However, Bara is not very as academic as I would have liked it to be, because now you're just pushing paper, you're pushing administrative work, you're pushing seeing the line, you're pushing seeing patients, basically. So there's just a lot for you to engage nicely into, like, the academic part of the internship. But in other rotations, you do get that. But in most of the rotations, it's just too much. I'd rate Bara maybe 7 over 10 from my perspective, because if you're looking for DQ, you literally rate it as 2. If you're looking for a nice work balance, you would rate it as 3. So I got what I wanted out of Bara. So be careful on why are you there. If you are here, you want to choose Bara because of a friend, I wouldn't advise that. DQs, not as well.
All right. Thank you so much. Do you guys have more questions? I don't see any more questions from the chat, and we have gone past the hour, but I'd just love to share my heartfelt gratitude to you, Dr. Njapha. You really opened my eyes. Bara was my first choice. I'm still considering it, but now Asia with caution.
But guys,
thank you so much.
Someone has to do it.
Yeah, someone has to do it. Yeah, don't sell us dreams and then go there and you get shocked. When I choose Bara, I know exactly what I'm going to be doing, you know. I think I yeah, I speak for most of us that are here. So thank you so much. This has been very, very informative. Yeah, I just wish you all the best into ComServe. Where are you planning to go for ComServe?
Yo, guys, that's another issue, hey. I'm not sure as yet because I'm still trying to put it in line with what I want to do
With your life.
after this, basically. Yeah.
But I'm sure you're gonna stay. Wherever you go, they're gonna be blessed to have a Dr. Njapha there. All right. Thank you so much, guys, for joining. I just want to say some announcements. So this was recorded and it will be shared with you guys on the SAMSU final year group. And then as well, we also have a website that we created where doctors are also writing their hospital reviews, and it is free. It is free. It's never going to not be free. We're just trying to put this information out there, you know, because I saw the other time SA Docs was free and then now it's no longer free. So we just, yeah. Thank you so much. Kenny, do you want to say something? I'm done.
No, you know, I mean, the doctor said the mouthful. Some of us who were considering, I don't think I will be going that side of Bara. But, you know, the doctor said the mouthful about everything. Yeah. So I think we'll send the link. We'll send the video, the recorded audio to the group so that everyone, maybe those who are on call were unable to join, then they would get the audio. I think, yeah, everything is fine from my side.
All right. Thank you so much, guys. And yeah, next week we'll have another Zoom Q&A session. Bye. Bye.